Good afternoon. I welcome our esteemed Saturday. Many of you are
Good afternoon, everyone. I'm very happy to invite you all for this wonderful second Hemophilia virtual case conference. Last time we had first virtual case conference where we discussed about the hemophilia and its complications due to the disease. Now in this discussion, the case conference, we have hemophilia and complications due to the treatment. We have eminent speakers from all over the country who deals with hemophilia in a day-to-day practice, and they are very well versed with the treatment options for hemophilia. So I welcome Farah Madam, who is a professor and head of the Department of KEM Hospital, and she is the organizing secretary, and she's consultant hematologist, PD Hinduja Hospital Medical Research Center, Mumbai, India. We have our first speaker, Dr. Tulika Seth Madam, and we also have hemophilia educational video, which is by our platinum sponsor Takeda. So we want to play this educational video regarding the management of hemophilia.
Hemophilia, journeying towards a life without bleeds. What is hemophilia? Well, when we get a bump or injure ourselves, our blood vessels can become damaged, causing a bleed. Most people don't notice this because their blood contains clotting factors, which work quickly to stop the bleed. But people with hemophilia, like Tom here, don't produce enough of these clotting factors. This means that Tom's bleeds last longer than most people's. Depending on where the bleed occurs in the body, some bleeds can require a hospital visit or even be life-threatening. Bleeds can happen anywhere, but in people with hemophilia, they are most common in the joints, where we move the most. When joint bleeds occur, they can cause painful swelling, inflammation, and damage. And sometimes bleeds just happen with no obvious cause. And it's not just pain that can affect Tom and other people with hemophilia. They may miss school or work, possibly from being bedbound because of a severe bleed. They may also miss out on spending time with their friends. And just 2 or 3 bleeds in the same joint can cause long-term damage in some people with hemophilia. There are thousands of people with hemophilia all around the world, and almost all are male. And their hemophilia can be treated by replacing the clotting factors which they lack. Regular infusions of medicine provide clotting factors in the blood to try to prevent bleeds before they happen, rather than treating them afterwards. This approach is called prophylaxis. The ideal goal for anyone with hemophilia is to live without bleeds. So prophylaxis is recommended by the World Federation of Hemophilia for people of all ages and backgrounds. The importance of personalized care. The key to successful prophylactic treatment is matching the right dose at the right times to the right person. Everyone with hemophilia is different. Their age, body, weight, activity levels, and genes all affect how much clotting factor they need and when. So they each need different treatment schedules. In other words, it's helpful for people to have a personalized care plan made just for them. The path towards that plan starts when Tom chooses not to compromise. He wants to avoid the painful and limiting effects of bleeding and to live life on his own terms. This decision leads Tom to his doctor. Together they talk about moving closer to a life without bleeds. That's when they discuss a personalized care plan. By reviewing Tom's unique characteristics, like his medical status and lifestyle, his doctor can decide how much medicine is needed and when it should be taken to better protect Tom from bleeds. A treatment plan is developed that is tailored to the rhythms of Tom's body and his life. Then Tom's on his way. With the support of his medical team, his friends, and his family. Together they track how well his treatment is working, and his doctor adjusts it when necessary. Ultimately, Tom wants more freedom to enjoy life with the people he cares about. He wants to look forward to his future and worry less about when the next bleed is going to happen. If you have hemophilia, talk to your doctor about personalized treatment options to help you prevent bleeds and protect your joints.
So we'll start our case conference. Our first speaker is Dr. Tulika Saik Madam. She's going to speak on 10 years patient with hemophilia with inhibitor titer 15 beta units, role of immune tolerance induction, practical issues. Next slide. So Dr. Tulika Saik Madam is, she has a major achievements to her credit. She is a Indian panel of experts drafted the NHM guidelines for thalassemia and sickle cell anemia. And she's a founding member of Indian Society of Evidence-Based Medicine. And she's a member of Delhi School of Public Health, examiner for DNB or NBE for hematology. And she has authorized more than 150 papers and more than 40 book chapters. And she's a guide and co-guide to for more than 30 DM, PhD and MD students, and member CEO AIMS and member of AIMS PG Ethics Committee. And she has done ITI treatment to many hemophilia patients. So I request, Madam, please, you start your lecture.
Thank you. So I'll share my slides. So I thank the organizers for this opportunity. And without further ado, I will start with the case. So the case I was asked to discuss about was a 10-year-old male with severe hemophilia, and he's already been diagnosed with an inhibitor, and his inhibitor titer is 15 Bethesda unit. Now, we all know that sometimes inhibitors can be transient. So if you have a very low titer, less than 5 Bethesda unit, you need to check if this could be a transient inhibitor. But in this case, we have a 15 Bethesda unit. So this is not likely to be a transient inhibitor. Now, what do we mean by immune tolerance induction? So basically in immune tolerance induction, it is a little bit like giving prophylaxis. You keep giving the factor until you are able to reduce the antibody production. So you basically exhaust the antibody production by giving repeated doses of factor. But because these patients have inhibitor, you have to also give bypassing agents or include other strategies for managing the bleeding in these patients. And the doses of factor that you give are much higher than the usual doses that are given in prophylaxis. So first and foremost, you have to identify a patient if you're planning to give immune tolerance induction. And to all my friends and colleagues, I always say that if you select the right case, you will get the best result. So because the amount of factor that you're going to need for these patients is going to be a large amount, it's a good idea when you're doing immune tolerance induction for the first time at your center to pick a younger patient, because a smaller size patient will require less factor. Obviously, if it's a low titer inhibitor, you want to make sure that this is not a transient inhibitor. You need to know the titer that you're treating. Sometimes patients with very high titer, like maybe 500 Bethesda unit, this may be a little bit difficult to do an ITI because they may have a lot of breakthrough bleeding and the results may not be so good. So we know that there are some predictors of ITI success. So patients with a lower titer at the time of starting, who haven't had a very high historical high titer, these are good patients to select. It is also important to know that you shouldn't start the ITI after many, many years, because then again, you're less likely to have a success. And you must avoid interruption. So you need to do a lot of planning. Now, because of COVID and the lockdown, actually, since last year, we have not started any new immune tolerance, because these are patients who should be seen in the hospital. They should have adequate supply of factor, and there should be no interruptions. And we've had a lot of problems with both the transportation and the factor and other things. So if your state is not undergoing any lockdown, that's good. The other thing you must realize is that monitoring is required for patients on immune tolerance induction, and we'll talk about monitoring in a little bit. And because you're going to be giving factor very frequently, minimum is 3 times a week, you may need a central line or some sort of home therapy, and you must have transport. And if the patient lives far away, then you need an alternative arrangement for emergencies. So the current scenario is not very good, but normally what we do is we calculate the amount of factor that we're going to need in the initial period, and then in case we're doing a higher dose, we calculate for that, and we earmark the whole supply of factor for a patient who is undergoing ITI, so that there is no chance of running out of the factor. You must sit down and have a good conversation with the family. This must be an informed consent, because the family has to participate and cooperate. The ITI mean period that we've had for patients to have their inhibitor eradicated is about 9 months to 1 year, but it can be 2 years, it can even be up to 3 years. The failure is actually not said until it's 33 months. So the family and the child have to be prepared for this. There are going to be many injections, many blood tests. They also need to be explained that the titers may actually increase during this period. And often the families get very focused on the titer level, and if there's fluctuations, or if there's a period where the titer increases, they get very discouraged and disheartened. Compliance is important, because even if you have the factor, if they don't take the factor regularly, it's going to be a problem. And you need to have a strategy in place with either bypassing agents, Novo 7 or FIBA, for breakthrough bleeds, because there will be bleeds. And there's also no guarantee that the inhibitor titer will be eradicated. The ITI success is about 70%, no matter what kind of a protocol you use. But there will be some patients who will not respond to the protocols. So the major protocols are the bond protocol, which uses about 100 to 150 units per kg, and this is given 12 hourly, which basically means you're getting about 200 to 300 units of factor VIII every day. And this is a daily regimen, and they give bypassing agents along with that. The Malmo protocol has, again, very high factor VIII. They also give immunosuppressants and IVIG. And then there's the Dutch or the von Kriewald protocol, which was initiated by Brackman. And this uses lower doses of factor VIII, 25 to 50 international units every other day. So this is roughly a 3 times a week protocol every other day, just like we do for prophylaxis. But again, with this protocol, you may have to give increments. And this is the protocol that we have used in our center. And we usually start with 50 units per kg every other day. So that's about 3 times a week. And then in case patients don't respond, or they have an increment in titer, then every 3 months, we can actually increase the dose by 25 to 50 units per kg. So this is the regimen that we have used. There are other strategies of doing ITI. People have added rituximab. People have done ITI with extended half-life factors. They've done ITI with Emicizumab prophylaxis. They've done ITI using a factor VIII product that contains VWD. But well, the current WFH 2020 recommends that a ITI should be started for all patients with inhibitors. We chose at our center to do the classic low dose ITI regimen. The difference between the high dose and the low dose, there's only one study, there's an international ITI study, and they found that the results were equal in both the low dose and the high dose. So it was 70% achieved tolerance. The difference was that the bleeding rates were higher in the low dose. So they had more breakthrough bleeds, and the time to achieve tolerance was again was slower in the low dose, though it was not that much difference. The only thing was that all patients who had a very high titer, they tended to do worse. So if you're starting to do ITI, don't take patients with this very high titer, because even with the high dose or the low dose, they may not do so well. So the product that is recommended is to use the same product with which they developed the inhibitor. But as I said, there are many other strategies of using either VWD product or extended half-life product. So just like when you're going on a journey, you need to prepare. So be prepared. Be also prepared for problems and other things that can happen. And so this is just a short course of a patient that we had. So this was a male who had been on episodic factor, and he'd had several bleeds, and he had tested with an inhibitor positive because he was not responding to the factor that he was usually responding to. And we followed him for a few months, giving him bypassing agents, but then realized that he really needed an ITI. So this patient was then started on the initial ITI. Initially, we started on 50 units per kg, and we continued to give him that. And initially, there was a fall in the titers, and everything looked really good until, unfortunately, the patient had an episode where he had a fall and a bleed. And with that, we found that his titers were going up. And so we increased by that time, it was about 3 months. So we increased the amount of factor we were giving, and we increased it from 50 units per kg to 100 units per kg. And we continued him on this along with bypassing agents for managing the bleed. And thankfully, the inhibitor titers subsided, and then we were able to manage this patient. So this is, it's very important to explain to the child that there will be ups and downs. And now just a little bit on the testing. Now, when we normally do the Bethesda assay or the Nijmegen Bethesda assay, there is a washout period. Now, in patients who are on immune tolerance induction, we do not want the washout period, because we don't want them to have, you know, a long period where they are not going to be getting factor, because this constant factor is actually what helps to reduce the antibody production. So there is a method which is done, approved by the CDC and was recommended by Miller, in which we actually do the sample after collection but before you do the Bethesda assay is heated at 56 degrees for 30 minutes. And this is very good, because especially for patients who have very low levels of inhibitor, you will avoid getting a false negative. Now, a false negative in this scenario is important, because you may think that you have eradicated the inhibitor, but actually the small amounts of factor that are there because you're doing the ITI, this will lead to a false negative, and you will stop the ITI prematurely. So when do you decide that this is successful? First, when the inhibitor titer is no longer measured. So either you have a washout period, but if you don't do the washout period, you will do the heat inactivation. You also should do a factor recovery. So you give a calculated dose, and you make sure that the recovery of the factor within half an hour of giving the factor dose is about 66%. And you can, if available, do a half-life of the factor rate. But we definitely make sure that these two factors are there, and we do the pre-analytic heat inactivation. And only then we say that we have a success. We recently, the first child that we had, when we started his ITI, he'd been 10 kilos. He came to us recently, and he's now 46 kilos. And he's back on prophylaxis for the last 5 years. So it's important to put these patients back on prophylaxis, because if you don't give prophylaxis, then again, the inhibitor will come back. Now, when you call it failure, sometimes you have to admit that there's a failure. And this is when you've given the proper ITI, and up to 33 months since you started the ITI, the inhibitor hasn't gone, and there's not even a 20% decrease in the inhibitor titer over 6 months. So that's considered failure, and that's when you may want to do different strategies for salvaging these patients. And the WFH also says that at least one trial of ITI should be done. And in case that one trial is a failure, then you can put them on prophylaxis with non-factor products. The reason being that the cost burden of putting a patient on bypassing agents for life is very, very large. So if you can eradicate the inhibitor, it's really good. So to summarize, the von Crewald or the low dose, it's very good. But again, try to not take patients maybe, I mean, I put 200 here, 100 here, but maybe 200. If you have a very high titer, maybe avoid that. The low dose ITI regimen is a very safe regimen, even though the high dose is better because you can have less bleeding episodes. But we actually found the low dose to be very safe, and we did not find many bleeding episodes in our experience. More people should do ITI, and we should pool in our data and help formulate our own strategies and see what else can be done to make this more cost effective. And that's the end of my talk. Thank you. I'm happy to take any questions.
Yeah, good afternoon, and thank you, Tulika. Can I be heard?
Yes, yes, ma'am.
Am I heard?
Audible, yes, very well.
Yeah, so thanks, Tulika. That was a very nice practical lecture. And before I go on to the questions asked by the delegates, I just would like to ask you, can you give us just a short idea of the expenses in the low dose, which we are doing over here, that are involved, and the expenses involved with the classical high dose ITIs? Just a little approximate idea.
So actually now the factor cost has come down a lot. So I won't be able to give you the actual cost, but we actually at our center, we do 25 units 3 times a week as our prophylaxis. So we have mostly patients who are reimbursable, and we give the intermediate dose prophylaxis. And so what we have found is that if you're using 50 units per kg, it's basically double the cost of your prophylaxis. And that is something quite doable for patients who are on ESI and CGHS. And as I said, most of the patients that we've done ITI have been less than 10 years old and did not have high titer inhibitor. The amount of factor that you're going to use for the high titer would be 200 units per kg. So you're going from 50 units per kg 3 times a week to 200 units per kg daily. So that is really exorbitant, and the advantage is not really there. So I think that's not a strategy that is feasible for most of us in India.
Okay, fine. So we'll take some of the questions from the delegates. The first question has been asked by Dr. Karim. When antibody production against factor, how are you going to treat those cases by immunosuppressive drugs? What are the drugs you commonly use and the dose?
So rituximab has been used. The Marco regimen uses cyclophosphamide, and other immunosuppressants have been used. However, the WFH 2020 does not recommend immunosuppressive agents upfront, except for hemophilia B patients who are on ITI. So I don't have any experience of hemophilia B patients with ITI because one, that's much more risky, causes anaphylaxis, and the responses are much less than hemophilia A patients. Now, for the rituximab, there's a Cochrane review where they reviewed rituximab therapy and they did not find it to be good. I know that several of my colleagues in India have used rituximab, but the Cochrane review was a large series of about 18 cases. What the foreign experts have said about rituximab is that yes, on the short term, it may reduce your antibody production, but the inhibitor may come back. So I don't have experience with immunosuppressants. I had wanted to just get an experience using the classical ITI before I incorporated any variations. And we started this as a study. We were fortunate to have 2 patients who were on the study, and then later on we were able to do a total of 5 patients who were reimbursable. And so we've gained experience on this. And I do think that the immunosuppressant agents can shorten this, but I think we'll have to continue them on other therapy too and follow them later, because if it's a short acting thing, the antibody should not come back. The advantage of this ITI classical is that I have experienced that patients even 5 years out continue to be inhibitor free. So that is definitely a good thing. We should always, if we're doing something, we need to see the long-term outcomes as well.
Okay, thanks. Thank you. We actually in our department have used some rituximab, steroids, and cyclophosphamide. Chandrakala, would you like to say a word on this, of what we have used?
Yes, we have used actually along with an ITI, we have used now. In the past, when we didn't had factors, we have used rituximab and cyclophosphamide when we did not had even bypassing agents. So that time we have used and we have seen a good response. But now we have used rituximab in 2 patients on ITI who was inhibitors percently positive. Our ITI also after 9 months they are percently positive. So we use rituximab along with an ITI and they are inhibitor free now. They are in prophylaxis. So we cannot use alone rituximab. We have to use with ITI. If they are high risk patients, we can consider rituximab. But data doesn't support actually evidence. There is no evidence for this actually.
No, I think we should collect this evidence and look for something.
Yes.
Yeah. There's another question which says the Bethesda units. What is the average value of Bethesda units with most of the patients?
So
that's a bit difficult to.
I think it's. I think what we have to realize is that patients will get inhibitors at different time points. Sometimes it also depends on whether it's after surgery. Often those patients will have very high titers. Some patients will have low. The most important predictor is actually the genetics. Unfortunately, we don't have genetic data on our patients, but there are families where all of them will get very high titer inhibitors. So there's no average as such, but if you have family information, like if you know a brother or a cousin or an uncle had a high titer, then it's very likely that this other patient will also get a high titer.
Yeah, so the titers basically can vary on individual patients. It could be anything as low as 5 Bethesda units and go up to even 200 or 300. We can't really predict that. The next question says that this is, I think, from a patient who says he has hemophilia A. He was taking factor VIII since birth. But in 2016, he got anaphylaxis 5 to 8 times and tested positive for inhibitors. After that, he took factor VII. Now in March 21, he's negative for inhibitors. But on taking factor VIII, he's still getting anaphylaxis. So he wants to know what he can do since he needs factor VIII lifelong.
So the thing I would...
It's rare to get anaphylaxis.
Okay, so anaphylaxis is more common with patients who have hemophilia B, but I would want the patient to be checked again for inhibitors, because if you don't take factor for some time, the inhibitor titer may actually come down. The only thing is that some of these patients, when they are exposed to factor again, they may have an anamnestic response in which the inhibitor may come back. Because actually, just because you've not provoked it, the inhibitor looks like it's disappeared, but because there's no immune tolerance induction that is done, on any exposure, they may again develop an inhibitor. So I hope this is not an inhibitor again, but I think it should be a good idea to recheck.
Okay. There is a question. There are a couple of questions which are not related to this topic, so I'm not going to take them. One question now is, can inhibitor titer level more than 500 units start ITI? I think Dr. Seth has already answered this in her lecture. You just want to reiterate, Tulika?
So in the West, they actually do go ahead and do it. And they recommend for high titer inhibitors, they should use the high dose regimen. I think in India, we have to realize that we have limitations. So I think if anybody's starting to do ITI, don't take a very high risk patient. Start with a patient who has a good chance. And, once you've got success, once your lab and everybody has experience, then if you want to and you have the abilities of doing a high dose regimen, then definitely go ahead. In the West, there is no limitation as such, but we are not the West.
Yeah, okay. This is a good question. What is the recurrence rate of inhibitors after successful ITI after instituting prophylaxis? Independent if the factor is same or different from the previous one.
So there's very little data on recurrence of ITI in the West, primarily because most of these patients are put on prophylaxis. So that is a very important thing that we need to do. Though, of course, there may be a few patients who may have their inhibitors come back. In India, I have seen some patients who got some ITI and then they were on on-demand therapy and the inhibitor came back. So I think I don't have numbers of how much it is there that comes back, but I think it's really, really important to remember if you have a patient who cannot go on to prophylaxis, then it's probably not a good idea to do ITI on such a patient because inevitably the inhibitor will come back in the future.
Okay. The next question is, in case of emergency bleeding, how much dose of ITI is required?
So in an emergency, if you need surgery or you have a bleed, then you have to go with bypassing agent. The ITI is a slow process. It may take 6 months, 9 months, 2 years. So there's no emergency in ITI. If somebody needs surgery, it's not something that, okay, let's quickly do ITI and get the inhibitor to go away because it's not very predictable. Some patients I've had, the inhibitor disappeared in 3 months, but that was just in 1 or 2 patients who had very low titer inhibitor. The majority of patients, the eradication took 9 months. So if you have an emergency, use bypassing agents, don't do ITI.
Right. Thank you so much, Dr. Tulika. And with that, we'll come to the end of this particular lecture. Like I said, there are a couple of questions dealing with specific treatment not related to this lecture. I request the delegates to please ask questions related to the particular lecture which is going on. And we'll go on to the next lecture now. Thank you.
Thank you, Tulika Madam, for a nice lecture. So we'll move on to the next lecture, which is also on inhibitors. So we have Dr. Neeraj Siddharthan, who is currently Associate Professor Clinical Hematology, Amrita Vidyapeetham, Kochi. He has done his MD in General Medicine and DM in Clinical Hematology and training in Government Medical College, Trivandrum and CMC Vellore. And his current position is Professor, Head of the Department of Clinical Hematology, Amrita Hospital, Kochi. Dr. Neeraj is also taking care of hemophilia patients and actively participates in most of the hemophilia programs. He is going to talk on 20 years male patient with hemophilia with inhibitors since 10 years and the new drug, what is the role of Emicizumab and what are the practical issues. Over to you, Dr. Neeraj.
Thank you, Dr. Chandrakala, and thank you, Farah Madam, for inviting me for this to this forum. I'm just sharing my screen. All right. I hope the screen is visible.
Yeah, it's visible and you're audible. Yeah. Yes, Neeraj. Yeah.
Thank you. So I'm asked to speak on the 20-year-old PWH with inhibitors. And he's been having inhibitors since 10 years. And now we are going to explore the role of Emicizumab and discuss the practical issues. So I'm going to call our patient as Mr. H. And so he's been having hemophilia with inhibitors for the last 10 years. And having inhibitors is indeed one of the major complications in hemophilia. So you have experienced a very high burden of treatment, and I expect him to have venous access difficulties. And at his age of 20 years, I think I would expect a low compliance with many of the treatments that he's getting, especially with the IV access. And also he would want to have a lot of activities, and he would be having a lot of breakthrough bleeds, because inhibitors are generally known to have more bleeds than their peers with hemophilia. And I believe his activities would be limited with the breakthrough bleeds. And his protection from joint damage is limited. And of course, he would be facing the economics of treating inhibitors, because 90% of the cost of hemophilia comes from treatment of inhibitors with bypassing agents and ITI. So that's why I discussed with him regarding Emicizumab, and he asked me, "Doctor, what is this Emicizumab?" So I have to explain to him. So I told him that this is a new drug. It looks like factor 8. It works like factor 8, but it is an artificially synthesized, and it is an antibody. What it actually does is that it replaces what the factor 8 does. You have the factor 9 activated here and the factor 10 here, and you have the Emicizumab here, which will bind both and then activate the factor 10. So this is essentially what the factor 8 naturally did. So what the factor 8 naturally did, Emicizumab is going to do artificially. So, and I told him, see, we have a lot of evidence for this. Drug is marketed. So he wanted to know specifically, what all patients it has been tried. So I told him about having 1, 2, 3, and 4 trials. Basically, it consisted of all kind of patients: hemophilia A with inhibitors, without inhibitors, pediatric patients, adult patients, adolescent patients, and they tried all kind of doses also. All the loading doses were similar: 3 mg per kg for 4 weeks. But the maintenance doses were either weekly 1.5 mg or 3 mg per kg once in 2 weeks, or 6 mg per kg once in 4 weeks. So efficacy was excellent. And because this was compared with other agents without prophylaxis with Emicizumab, and there was a significant reduction in annual bleed rate from 89 to 99%. And in all the trials, it was similar, but there were some safety concerns in the HAVEN-1 trial. I'll explain to him in detail, but there were some patients who developed serious adverse events like thrombotic microangiopathy and thrombosis. But that didn't repeat in other trials. We'll go into that. So I told Mr. H that, you could consider this drug because it is approved for your age, and you can take it by subcutaneous injection. And it comes in different formulation, and the half-life is about 4 weeks. Now, I also explained to him with this graph that, it will take about 4 weeks initially for the drug level to reach a plateau. It steeply rises to a plateau, and then it is maintained at the plateau at different ages and at different doses. There are slight differences, but more or less these are been similar. What he was most excited about was that he could take the injection himself. It is a subcutaneous injection, and there was no need for an expertise to get the vein. You could do it himself by injecting in the thigh or the abdomen, or he could get a help of somebody and inject it in the upper arm. So I also showed him, specifically for inhibitors, what is their efficacy. As you can see in this graph, in the hemophilia A with inhibitors, there was almost a 90% reduction in the annual bleed rate. And looking at all the trials together with inhibitors and without inhibitors, very interestingly, the median annual bleed rate, the middle value was 0. So, which means more than 50% of the patients, in fact, it was much more than that, had 0 bleeds with the drug. So Mr. H was very impressed. He said, great drug. But doctor, what about, you said about some safety problems. What are the safety issues of this drug? So I said, yes, we have safety issues reported with this drug in the first trial, Heaven 1. First one was the thrombotic events, and there were serious thrombotic events described in 2 patients. And when they dissected that, they found that these 2 patients had received at least 1 dose of APCC while being treated with Hemlibra. So, and in both these patients had an average cumulative APCC dose of 100 units per kg per 24 hours for 24 hours or more. So one case was a cavernous venous sinus thrombosis, another was a skin necrosis. And one patient had resumed Hemlibra after the resolution of a thrombotic event. But these were the 2 thrombotic events, and after that, no other thrombotic events had been reported. And I told him that even in the recent blood journal publication presented a 2-year follow-up data, and in that also there was no more thrombotic events described. The other complication which I explained to Mr. H was thrombotic microangiopathy. That there were about 3 patients out of the 373 who received Emicizumab and at least 1 dose of APCC they also had received. So there were 31 of those patients, out of which 3 had developed thrombotic microangiopathy. And again, in these patients also, they had received a cumulative dose of more than 100 units per kg for 24 hours or more. So in one of these patients, the patient had a rectal hemorrhage, which was fatal. At the time of the rectal hemorrhage, the thrombotic microangiopathy was improving though. So another patient resumed Emicizumab without recurrence of thrombotic microangiopathy. And as I said again, even the TMA also has not been reported after that, after many safety measures were put in place. So what are the safety measures that we have to consider while giving Emicizumab to any patient? So as a physician, we should tell the patient, and I told Mr. H that you should try and avoid APCC as far as possible when you are on Emicizumab, unless you don't have any other treatment available. But because if you have a recombinant factor 7, then you could use that. For a patient without inhibitor, they can use a factor 8, sorry, and a patient with a low titer inhibitor also, they could try a higher dose of factor 8. Sorry. So if sometimes in our country we can talk about theory, but practically sometimes it may not be feasible, it may not be available, it may be very costly. So now, if at all you are in a scenario where you have to use a bypassing agent and only APCC is available, then the initial dose should not exceed 50 units per kg. It is recommended that generally people would start with 25 units per kg. And the total dose should not exceed 100 units per kg in the first 24 hours of treatment. And you would really have to weigh the risk of TMA and thrombotic events when considering more doses. And these patients, you would definitely want to keep us in patient and monitor for thrombotic events and TMA if you are really having to administer APCC. But as far as possible, try to avoid that. Now, recombinant factor 7 with Emicizumab, the trial data was analyzed and although there was a theoretical concern of thrombotic complications, there were no thrombotic events associated with the concomitant use of factor 7 for bleeds and surgery. So the safety profile, dosing intervals, and dosing was consistent with the labeled indication of recombinant factor 7. And in general, these doses of factor 7 also, we start with the lower dose like 90 microgram per kg rather than the 270. So after listening to this Mr. H was very impressed, and he said, maybe I will try and take Emicizumab, but doctor, please tell me about the how I should be monitoring, because now I am checking my in vitro titers, and I keep checking that. Previously, I used to check my factor levels. So how do I monitor my laboratory variables? So this is a little bit tough, I told him, because you have the global correlation tests to measure, you have the Emicizumab levels, you would want to measure the factor VIII activities, you would want to measure the actual inhibitor levels, or you could also look at a scenario where some patients would develop Emicizumab antibodies, and then you may want to measure that. So I told Mr. H that, look, when you are on Emicizumab, it may look like the Emicizumab is similar to factor VIII, and you're getting all the benefits of factor VIII with Emicizumab, but you're actually it's not the same. There are a lot of differences between that. To elaborate on that, it will require a detailed session, so I'm not going to go into that, but a little bit. Factor VIII has a short half-life, and Emicizumab has a really long half-life, and there is some difference in binding with the factor 9, factor 10, and the activated factor 9 and factor 10. Emicizumab will have similar binding affinity to the activated and inactivated factors, but it doesn't bind to bovine. That's going to be important in designing some of the assays. So even this is reflected in the lab tests that we do. So there are tests which are affected by Emicizumab, and then there are tests which are unaffected by Emicizumab. Activated partial thromboplastin time is usually shortened, by Emicizumab. Bethesda assays, the plot-based assays, are usually affected. Factor VIII activity is affected. APTT-based APCR is affected. Activated clotting time is affected. Now, the bovine chromogenic assays for Bethesda is not affected. Thrombin time is usually not affected. And the chromogenic-based other factor assays are not affected with the Emicizumab. So, first I'll deal with the global coagulation test. I told Mr. H that, look, there are so many tests are there, but practically what we can do is, one is we can do APTT. The APTT before starting Emicizumab is going to be prolonged, and after starting Emicizumab, it is likely to be coming down and probably normalized, or it will maybe even low. But it is not like a one-to-one, going to be measuring the plasma level of Emicizumab or efficacy of Emicizumab. But serial monitoring sometimes may help, and it's a very simple test to do. The other test is thrombin generation. And I'm not sure whether many centers will have this, but I told Mr. H that specialist centers will have thrombin generation. It can be either done by ROTEM, so like INTEM and NATEM in ROTEM, or it can be calculated in thromboelastogram, or you could have a standalone thrombin generation assay. So these actually can give a fair idea of the thrombogenicity or the efficacy of Emicizumab. So essentially, on your left, you can see the thrombin generation test, and on the right, you have the TEG. And in TEG, from the TEG, you can have the maximum amplitude, and then you have a calculation by which you can actually try and generate the thrombin generation results. So the effectiveness of Emicizumab to monitor treatment, sometimes practically we use this, although globally there are different other tests that have been designed. The original Heaven trial used ELISA test to look at the Emicizumab levels. However, these ELISA tests were specifically designed for the studies, are not widely available. So many centers have now tried and looked at, looking the old one-stage factor assay and to try and replace with the Emicizumab calibrator and controls. So I can see that in this graph, it is the one-stage assay replaced with Emicizumab calibrator and controls had a fair correlation with the ELISA. So that's one one thing which if some of our labs may be able to do in the future, I guess. Now, if you actually want to do the factor 8 levels while on emicizumab, I'm not sure how many of us really want to do a factor 8 levels while on emicizumab, but if at all, we will have to do, because sometimes it may be needed for a patient who doesn't have inhibitor. So, it is important that, we understand the limitations. If you do a factor 8 assay, you're going to find values like 500 or 1000%, etc. And that's for the one-stage assay as well as chromogenic assay, it's going to be the same. But if you use a bovine factor, a bovine plasma, then that emicizumab will not bind to the factor 10 and 9 in the bovine as previously discussed, and then you could get a proper value there. The same with inhibitors. If you use a classical Bethesda while on emicizumab, you're going to get a false negative values, and so that's not going to be correct. So actually what we should do, if you really want to assess, many people wouldn't want to assess this because the patients are going to do well without bleeds and they're no longer bothered with whatever is the titer. But if you really want to know the titer, because some people are trying to do ITI with emicizumab. A trial is ongoing called Atlanta trial. So if you really want to do the test, then it has to be done by bovine chromogenic assay. So it's a bovine protein-based chromogenic assay for the Bethesda assay while on emicizumab. So, that's a little tough. That's what Mr. H told me. But he has now nevertheless made up his mind that, okay, I may not require much of lab monitoring, but a little bit of lab monitoring, safety is good. If I take good care, then I may not, I have good efficacy medicine. So one last question, doctor, he asked me and says, suppose, I do a lot of biking and, I sometimes are prone to trauma, sometimes, I wonder if I get injured or if I need a surgical procedure, what medicine should I be using? Will this cover if I need a surgical procedure? So I said, yeah, I will need to discuss with you this because you will have to divide surgeries into minor procedures and major procedures. And, the Heaven trial actually looked at their data on minor surgeries, and there were about 141, 215 minor surgeries, and out of which about 141 out of them did not require any support, and this itself was enough. Emicizumab was enough, and some of them actually required additional clotting factor concentrates. So they were divided into dental procedures. So in the dental procedures, out of 42, 29 did not have any bleeds, and 13 had bleeds, and 9 bleeds were treated with clotting factors, and 4 bleeds did not require treatment. So in the venous access device procedures, 23 out of 25 did not have bleeds, and out of 2, 1 was treated with clotting factor and 1 was not treated. Similarly, there was some endoscopic procedure and arthroscopic procedures. Majority of the procedures did not require any factors, and in some of the bleeds did not require factors. So the CFC, wherever the bleed did not require factors, they have mentioned that they have used drugs like tranexamic acid. So that was an important thing. So, summarize the surgical procedures, I think minor procedures, if it's an elective surgery, it's important that you wait for about 4 weeks after the loading dose for the dose to build up, and roughly it is somewhere between 10 to 20% of equivalent of factor 8. I think the level stays. So for the minor surgeries, some of them may not require any further support. In dental, in general, there is a practice that in addition to emicizumab, you give tranexamic acid locally. And if at all you have a breakthrough bleed, then recombinant factor 7 is preferred. And the dose is 90 microgram per kg. And for major surgeries, the CFC support is required mostly. So in summary, I explained to him about the safety and relatively safe, efficacy, very efficacious drug, relatively safe. You have to be cautious with the concomitant use of bypassing agents, and it has been judiciously performed, and recombinant 7A is preferred. Lab monitoring requires expertise in testing and interpretation. APTT and thrombin generation are the commonly available tests right now with us in India, and emerging data on minor and major surgeries with Emicizumab alone or with the recombinant factor 7A and Emicizumab. With that, I conclude. Thank you very much.
Thank you, Neeraj. That was very nice. We'll quickly go to the questions since we are running short of time. This is from a patient who says that he is on regular Emicizumab. If he has an emergency bleed, which should he take, Novo 7 or FIBA?
Yes, so I think I have discussed this during the presentation. The first choice is definitely factor 7A. And if factor 7A is available, factor 7A should be taken at 90 microgram per kg. Whereas if factor 7A is not available, you can start with the FIBA dose of 25 units per kg at a lot of 7. But if you are taking FIBA, you should be monitored for thrombosis and thrombotic microangiopathy.
Okay. Can you use Emicizumab? This is from Dr. Kareem. Can you use Emicizumab? Is it beneficial in patients with high titers of inhibitors, for example, 200 beta-sida units?
Yes, indeed. In fact, it is efficacious in both high titers, low titers, and without inhibitors. So inhibitor titer doesn't matter at all because the antibodies to factor VIII doesn't affect the Emicizumab functioning.
Right. Is there anything similar like Emicizumab for hemophilia B patients?
Yeah, so at present in the market, I think we don't have anything, but and the other bypassing, other non-factor concentrates like fitusiran and concizumab are undergoing trials, and hopefully we should have something approved for hemophilia B in the future.
Yes, so there is something in the pipeline, Dr. Shetty, but I think in a year or two, it should be available even commercially. For long-term treatment of patients, what is more feasible, factor VIII or Emicizumab, in terms of efficacy and cost?
So I think this is for a patient without inhibitors. So yeah, that's for a patient with inhibitors. I think we should try and do the cost analysis, because we had done a cost analysis in a couple of patients who were requiring bypassing agents for on-demand therapy, and who had taken Emicizumab for 6 months. So we had a 6 months to 6 months cost analysis done, and then surprisingly, the Emicizumab time 6 months was turned out to be much cheaper than when they used the bypassing agents. So
right. Okay. This is this a future replacement for treatment of inhibitor patients and normohemophilics? Probably yes.
I think yes.
It's a cost. Right. There is another question. It's not directly related, but I'll just give it from a Dr. Prasad. They have an elderly patient, age 70, and an 11-year-old patient. Both have hemophilia A mild and both have inhibitors. They say they do not have anything else to treat them with except large factor doses. So what are your suggestions? You know, this actually, I'm sorry, Dr. Prasad, answering this question would be, I think, a whole lecture by itself. And we are planning in the next 2-3 months having a similar webinars dealing with basic treatment of patients, you know, not all the fancy stuff. So I would very much like it if you could sort of attend those seminars, because definitely we will be addressing questions like yours. Chandrakala, I want to go back to the question that we took earlier, because this patient is rather desperate. And Neeraj, you can also try. He is a factor VIII and he says he gets anaphylaxis with recombinant factor VIII. What should he do? He's sent the question 2-3 times, so I think we should address it. Any ideas?
Madam, actually, we have one of our patients who has every time we give him plasma-derived factor, he has an anaphylaxis, and we give him only one type of recombinant factor. Not we have many types of recombinant factors with us, but this patient actually responds and with no anaphylaxis and no reaction, only with one type of factor, actually factor 8. So maybe because patient has to see the which type of factor 8 is taking, he might change. If he is having allergy reaction to maybe recombinant one type, he might change to other factor, or he might change to plasma derived. We can't explain. It's mostly we see in inhibitor patients. So we have to confirm he doesn't have inhibitors. If there is no inhibitors done in a proper lab, then he can change the type of factors he's getting. That's the only way we can treat him, madam.
I would also
Right. So
yes, ma'am.
yeah, you want to say something,
No,
Neeraj?
no, just that I completely agree with Chandrakala that the high suspicion of inhibitors, because anaphylaxis is where the immune system responds fiercely. So he should really double check his inhibitor titers.
Right. So, Himanshu, this is for you. So what they have suggested, one is you recheck your inhibitors from a decent lab. And if you are still inhibitor negative, then you try different products and see which one is not going to give you anaphylaxis. I mean, that's the only suggestion we can give, because you're probably getting the anaphylaxis due to something in the preparation that is being given to you. So you'll just have to try and see, because I'm sure it may not happen with all the preparations. So try and see which preparation does not cause anaphylaxis for you, and then stick to that. And with that, we come to close with this. Yeah.
No, he would be a good candidate for Emicizumab if because
right. Yeah. That's the other thing. I thought of it depending on expense, but otherwise you would be a good candidate definitely for Emicizumab. With that, we come to the end of this particular lecture. Thank you, Neeraj. And we go on to the next lecture. Once again, I would like to tell the delegates, please stick to questions regarding the particular lecture that is going on, so we don't waste time.
So we'll move on to the next lecture. Dr. Shashi Apte is actually held up with some work. So we'll have a talk by Dr. Rajesh Patil. So Dr. Rajesh Patil is a consultant hematologist and BMT physician. He has done his MD in general medicine, DM in clinical hematology, and fellowship in bone marrow transplant in CMC Vellore. At present, he is working in CTC PHO BMT Center as a consultant hematologist and BMT physician, and he's also consultant hematologist in Whitney Hospital, Thane. He's going to talk on what is actually the present scenario we're facing. Is like a lot of patients we are having this COVID second wave. So he's going to talk on COVID-19 and COVID-19 vaccine from hemophilia perspective, because a lot of patients has got queries and they come always, and so it's easy for us to sort out the issues. Over to you, Dr. Rajesh.
Yeah. Is my slide visible?
Yeah. Yes.
Good afternoon, everyone. Thank you, organizers, for this opportunity to talk on COVID-19 and COVID-19 vaccine in hemophilia perspective. So as we know, in the end of 2019, an epidemic which is focused in Wuhan part of China, and which is supposed to be came from the seafood market in China, has taken over all of the world and become a pandemic situation. We know that this infection spread from person to person from a respiratory droplet point of view, and the clinical presentation can be varied. It is mostly asymptomatic or can manifest as mild flu-like symptoms, and can become as severe to cause a severe form of interstitial pneumonia, or what we now know as a severe form of coagulopathy, causing in 15 to 20% severe coagulopathy causing death. So what this COVID pandemic has posed the challenges for the hemophilia community. So as Tulika Sit Madam had said, that the access to hemophilia treatment the mainly it is hampered because of the whatever the restriction which are posed because of this COVID-19 pandemic. The delivery of replacement therapies has been hampered. So in developed nations, though there is no problem regarding the availability, but because of the lockdown and manpower issues, while in the developing and poor countries, who mainly depend for the supply on the humanitarian basis of factor, the factor delivery was an issue, as well as the production of the recombinant DNA factors were issue because of the manpower and transport issues. While because of the shortage of the many plasma donors, the generation of plasma derived protein factors were derailed. And this lockdown has also given a significant impact on the regular medical follow-up and assessments and different consultations. As madam has said, that the specific therapies which are given to the hemophilias like immune tolerance induction, they have severely hampered, and many centers are not able to provide such therapies, as well as many diagnostic procedures, many educational programs for the physicians, for the families, as not able to hold up. Many elective surgeries were postponed because of the COVID-19 pandemic, and this has and pandemic has negatively impacted all the clinical research and the funding to the hemophilia worldwide. So coming to the COVID-19 per se effect in a hemophilia patient. In March 20, a first case of COVID-19 in a hemophilic was reported from China. That was a hemophilia with mild symptoms, which is managed with the IVIG infusion and the supportive care, and later on with full recovery. So at present, with the available evidences, there is no indication that the patients of hemophilia, those either on prophylaxis or either on on-demand basis, are at increased risk for the COVID-19 infection or at the increased risk of more severe COVID-19 disease. So the indications for hospitalization for hemophilics are the same as of other patients who don't have any other bleeding disorder. So what we should do when we get admitted for the COVID-19, at the admission counter and to the treating physician, we should inform regarding our disease, whatever bleeding disease it is, hemophilia or VWD, regardless of its severity. Diagnostic workup, which is more commonly done by the nasal swabs, that is no difference between this diagnostic workup for a person with hemophilia and another normal persons, and there is no hemostatic support required for these nasal swabs. Initial laboratory workup which is required for COVID-19 is more or less same for the other patients, which is like CRP, full blood count, renal function test, prothrombin time, APTT, fibrinogen, ferritin, D-dimer. For the patients with hemophilia, we can also do inhibitor screening if there is no recent inhibitor reports are available, and those who have the availability of factor assay, we can get a factor levels also done. There is no difference in the indications of the chest imaging for a person with hemophilia. Only if the person is requiring invasive intervention like arterial blood gas analysis, we have to supplement the factors and keep the factors level more than 50% in such scenario. So as we can see, these are the common tests which are done at the admission for any COVID-19 patients. Prothrombin time, there is no difference in non-hemophilic versus hemophilic. APTT time, as we all know, it is prolonged in those patients with factor VIII and factor IX deficiency. And as Dr. Neeraj has rightly said, APTT will be short in those patients who are Emicizumab, so we have to take this into the account. Otherwise there is no difference between platelet count and fibrinogen. D-dimer, only those hemophilics who have a severe bleeding or those who are using bypassing agent will have a D-dimer elevated irrespective of their COVID-19 coagulopathy. So for those hemophilics which have a mild factor deficiency, as we know that this COVID-19 infection can lead to inflammatory response and lead to increase in the factor VIII levels. So there might be increase in the levels of factor VIII in the mild hemophilics, and before starting any therapy, if there is a facility available, they can get a factor VIII level checked. And as we already mentioned, that Emicizumab will have a falsely normal or shortened EPTT because of its mechanism. So regarding the thromboprophylaxis in COVID-19 patients who were PWH, is that here the concept of standard dose venous thromboembolism prophylaxis is like what we take as enoxaparin of 40 milligrams once a day. Escalated dose is like 1 mg per kg once a day, while therapeutic dose is 1 mg per kg twice a day. So as the COVID-19, it is more or less similar to as what are the COVID-19 guidelines. Outpatient department. There is no need to give generally any VT prophylaxis. It might be considered to case basis for those patients who are at high risk of thromboembolism, like those who have severe obesities, those who have history of thromboembolism or having active cancer. Otherwise, those patients who are ward, they generally receive a standard dose thromboprophylaxis. Those patients who are in ICUs, it is recommended that they should be on escalated dose with prophylaxis, which is with enoxaparin 1 mg per kg once a day. While those who are there is confirmed diagnosis of venous thromboembolism or pulmonary embolism, or high likely chances of pulmonary embolism, those should go on therapeutic dose anticoagulation. And as they have written that ARDS might be a representation of a pulmonary microvascular thrombosis, escalated dose thromboprophylaxis can be considered in this scenario even without obvious evidence of thrombosis. So after discharge, while there is no specific data exist what to do after discharge, but it is reasonable to consider the extended thromboprophylaxis for those patients who has a high risk of thromboembolism with lower risk of bleeding. Like I said, those patients who were obese, those who have history of thromboembolism, who have active cancers, for them extended thromboprophylaxis can be considered for 3 to 4 weeks. So coming to the factor institution for these patients who are on thromboprophylaxis, as we already know that outpatient patient don't require any thromboprophylaxis, they can continue their factor 8 and factor 9 substitution as their prophylaxis program. Those patients who are who are in wards, and those who required a standard prophylaxis, which is enoxaparin 40 milligram once a day, for them factor 8 level should be maintained more than 30% at trough, with avoiding peak more than 100%. A similar more than 30% factor should be maintained for those who are hemophilia B. Those patients who are in ICU or ARDS, for those patients, as we know, there is escalated dose or intermediate dose prophylaxis, which for enoxaparin comes with the 1 milligram per kg once a day, or maybe 60 milligram once a day. For them, the factor level should be maintained between 50 to 100% for factor 8 deficiency, while it should be 50 to 80% in factor 9, because as such in those factor 9 deficiency patient, factor 8 level will be high because of the COVID per se coagulopathy. Those who have a proven pulmonary embolism or DVT will receive enoxaparin in therapeutic dose, which is for enoxaparin is 1 milligram per kg twice a day, with maintaining the factors level between 50 to 100% for the hemophilia A and 50 to 80% for hemophilia B. So for what to do for those patients who are on Emicizumab? For the Emicizumab ward patient who require a standard dose prophylaxis, there is no need to give additional factors. This is for those patients who are on Emicizumab with hemophilia without inhibitors. Those who are in ICU requiring escalated or intermediate dose prophylaxis, for them additional factor 8 or factor 9 should be instituted. Those who have a proven pulmonary or deep vein thrombosis, them also require additional maintenance of factor level 50 to 80%. So what care we should do when this patient of hemophilia gets ICU admission? So it is recommended that their factors level should be maintained between 50 to 100%, as we saw that they will require a therapeutic or intermediate dose of thromboprophylaxis. And if possible, daily biological monitoring of their hemophilia replacement therapy should be done. So presence of severe arthropathy should always taken into account while positioning of the patient, as we know that prone position ventilation helps in the patient with the COVID-19 pneumonia. We should always look for the severe arthropathy and take care of that. Also, these patients are more prone for nerve compression during the positioning, so we should give adequate attention to that. For those who are critical, there is no contraindication for the ECMO, is extracorporeal membrane oxygenation, provided that we have maintained the levels around 80%. So a few slides regarding the COVID-19 vaccine. So as we all know that in December 2020, UK has first approved and started the vaccination, and in January 16, 2021, it has started in India. The rationale is the same, to provide the protection against the COVID-19. And how this COVID-19 vaccine works. It stimulates the immune system to produce the antibody against the virus, and it also helps for developing a memory lymphocytes or memory T cells, okay, which retains the memory and ability to fight off the virus if they get exposed. So COVID-19 vaccines, generally 3 types of vaccine. Like what we are administering to the patient, we can administer a protein component of virus for which against which there will be antibodies and immune response, or we can administer some genetic material like a mRNA, which will create an immune response, or we can use a vector vaccine, which is another weakened virus in which the protein of the COVID-19 virus has been introduced. So the Covishield, what vaccine it is used of AstraZeneca, is a vector vaccine. Well, there is another vaccine which is Covaxin. Covaxin is a kind of killed vaccine. So at present, there is no particular reason to recommend one vaccine or the other for any bleeding disorder patient. The vector used in AstraZeneca is adenovirus. It is different from the AAV virus, which is used for the gene therapy of hemophilia, and it do not have a cross reactivity. So there is no particular preference for the vaccine for hemophilia patients. So while administering vaccines to PWH, vaccine should be administered intramuscularly with smallest gauge needle, and pressure should be applied for at least 10 to 15 minutes to that area, which reduces the bleeding and swelling. For additional 2 to 4 hours, we should inspect and palpate this area to notice whether there is a delayed hematoma or not. So those who are on regular prophylaxis, they preferably should take vaccine after taking their regular prophylaxis dose. Otherwise, those who are on on-demand basis, they can directly take a vaccine and just follow the precautions as mentioned earlier. Vaccination has not shown to prime factor 8 or factor 9 inhibitor formation. The mild hemophilics who have factor 8 level less than 10%, they might need a hemostatic treatment before vaccination. Those who are more than 10%, there is no need to give any factor. And definitely, as we have come to know that those who are on Emicizumab, there is no need to take an extra factor before vaccine. So those patients who have allergy or anaphylaxis to the blood products but not have any reaction to previous vaccine, they are not at any greater risk of COVID-19 vaccine. While those patients who has history of anaphylaxis or allergy to the PEG containing clotting factors, they should discuss with their physician that whether this vaccine they are opting for, whether it contains PEG or not. At present, the vaccine AstraZeneca vaccine do not contain PEG. The vaccine by Moderna and Pfizer, they do contain PEG. mRNA vaccines contain PEG. Thank you very much for this opportunity to discuss this topic.
Rajesh, thank you very much. Just before that, take the questions, I want to ask you, so you maintain a level during the while taking the vaccine of what, around 20%? What is the recommendation?
So madam, they are saying more than 10% is a good enough.
Okay, so we would calculate at 10% to give.
Yes.
Before giving the vaccine.
Yeah.
Right. Yeah. We'll go on to the questions. The first question you have already answered. Somebody is asking whether the patient can take Covishield or Covaxin. You can take either. There is no preference. The next question is, this is a hemophilia patient who is on trial with Emicizumab, and he wants to know whether he can take a COVID vaccine and if there is any complication.
So regarding vaccine per se, actually there is no particular guidelines came for these newer therapies. So what they have advised that for the manufacturer, they can actually communicate for this, whether there is any component which contains any particular component for which there is contraindication or vaccine or not. Up to Emicizumab and factors, there are the clear-cut guidelines there. For other therapies, they are advised to contact to the production like this or company who's supplying that.
Okay. The next, in the previous lectures, there was a question by somebody who said she's the factor 10 deficiency and can she take the vaccine? So I'll just answer it quickly. Yes, you can take the vaccine. Dr. Rajesh has already answered all the questions as to how the vaccine should be taken. The next question is, should one add low dose aspirin because COVID thrombosis can be both arterial and venous?
So if for asymptomatic patient, there is no role of any anticoagulation per se. Only those who requiring hospitalization should go on a prophylaxis, and antiplatelet agents data is not very clear at present. So there is no recommendation we can do for aspirin at least.
Okay. The next question is, steroids are given in severe COVID infection. Can it be given safely in people with hemophilia who have high titers of antibodies?
So steroids are in general can be given to hemophilics, but we should always know that steroid can cause a gastritis and all. So the treating physician should know that you have a hemophilia and they should maintain the adequate factor level. If you are receiving steroids, it means you are the candidate for anticoagulation, and you should maintain your factors level between 30 to 80% as I have described already.
Yes. So here it's not just the steroids. You're also going to consider that the patient who needs steroid will probably also need anticoagulation. So both the things have to be taken into consideration. Per se, there is no problem in giving steroids if you have antibodies, because at one time we used to try and use steroids, in fact, as a treatment to antibodies when we never had anything at all. So 1 minute, any other questions? This is a patient, she says she's a lactating mother of a 21-month-old boy and she has VWF. Should she get the vaccine?
So I think the UK Royal Society has given a guidelines, and according to them, those who are more than 6 months, 6 months from lactating and whose baby is taking outside food also, they can safely take it. And that is for the vaccines which are used in UK. Per se, the vaccines we are using in India and the lactating mother, there is no adequate data for that, as per my knowledge.
Yes, but I would also like to tell this person that if her boy is 21 months old, she shouldn't be lactating anymore. Right? She should have weaned him off by now. Okay. The next question is, can a person with hemophilia take the Johnson & Johnson vaccine?
So
I don't know.
I'm not aware, because but they can check it, because Covishield and Covaxin only we are aware at present.
Right, exactly.
Madam, there is one more question, madam. One more question. With COVID with high titer inhibitor in ICU, how will you maintain factor 50%, and which one you will choose? Like, is a high titer inhibitor, that's what they mentioned in ICU.
So if the patient who is an inhibitor and he's not on Emicizumab, so it is not recommended to give a thromboprophylaxis in them actually, because you cannot give a bypassing agents and maintain levels in them. If they are on Emicizumab, then only a low dose standard prophylaxis only we can offer.
I think that's about it. The other two questions are not very relevant to this particular lecture. There's something about plasma therapy and hemophilia. Like I said, not relevant to this lecture. We will be taking lectures on basic treatment of hemophilia sometime in the next 2-3 months. So I hope you all will join in at that time and we'll be able to answer those questions. So with that, thank you, Rajesh. Thank you very much.
Thank you, madam.
And we'll go on to the next lecture.
So we have the next lecture is surgery in hemophilia with inhibitor. Is given by Dr. Cecil Ross. Cecil Ross sir is head of the Department of Medicine, and he is in charge of hematology in St. John's Medical College Hospital, Bangalore. Sir has obtained MBBS from St. John's Medical College, Bangalore, MD from Government Medical College, Bellary, 1996. He obtained his specialty training in CMC, Vellore, and Royal Fred Hospital, London, and St. Louis University, USA. He started his hematology services way back in 1990. And Sir has done a Twin of the Year program by WFH in 2001. And he has got a Glue Grant from DBT for research in leukemia and training mid-career medical faculty. And he's a founder member of Hemophilia Society Bangalore chapter, and is currently the professor of medicine and head of hematology, St. John's Medical College and Hospital, Bangalore. And is the national vice president medical of Hemophilia Federation of India. And his research interests includes recurrent pregnancy loss, thalassemia, and bleeding disorders. Thank you, sir. Over to you, sir.
My screen has disappeared, so let me, yeah, okay. Yeah. Yeah. So thank you, Chandrakala, for introducing me kindly. So what I will do is I will talk to you on the management of surgery in patients with inhibitor. So what we will start off with is impact of inhibitor development on surgery. We will then move on to considerations for surgery in patients with inhibitor. Then we'll talk about the use of FIBA, NovoSeven, and Hemlibra in the context of surgery, and then top it up with the take-home message. So if you actually look at the magnitude of the problem, if you see the total number of patients who actually receive either plasma-derived or recombinant products, either of the two, you have patients who develop inhibitor, something about 15 to 35% across the country, but a large majority of them, 60 to 65 to 85%, do not develop inhibitor. So the 15 to 35% who develop inhibitor pose a major problem. And when you have a patient with inhibitor, those 30% or so, if you are a high responder, you cannot give factor replacement because they will neutralize, the product gets neutralized. But supposing you are a low responder, you probably can give a little higher dose, and you can see the cost of factor replacement in patients without inhibitor approximately is 30,000 rupees, whereas with low inhibitors it goes up to 1.5 to 2 lakhs. But if you have a high responding inhibitor, you have to use either FIBA or NovoSeven. And if you use FIBA at recommended doses, it's approximately 6 lakh rupees. And if you use NovoSeven at the recommended doses, it will be about some 11 lakhs or so. So this is the problem of surgery in hemophilia. And therefore, this is a slide that I got from Chandrakala, the data from government of Maharashtra that says the large number of patients in Maharashtra who don't have inhibitor, 4,500 in the database, and only about 150 patients are there who have got inhibitor. Now, if you look at the resources that are consumed, the 150 patients consume about 11 crores for the management, whereas the balance 4,500 and odd people consume only 1.9 crore rupees. So you see the amount of money that goes on if you develop inhibitor. So that's the magnitude of the problems. So just to understand what is the meaning of an inhibitor, a Bethesda assay. If you have a assay, Bethesda assay of about 1%, it neutralizes about 50% of factor activity. And therefore you can see that if you have say 2% and if you give factor VIII, which actually should have been at 100%, you will actually get about 10 to 20% in a matter of half an hour or so. And by the time the factor disappears out of the system and there'll be no more factor. And therefore, if you look at what a clinically significant bleeding, which requires treatment, it's more than 6 Bethesda unit. You have a low titer people and you have a high titer people. The higher the titer, the larger the capacity to neutralize factor VIII activity. So that is the importance of understanding the Bethesda assay. So what do you do if you have patients with high titer inhibitor all doses of factor VIII, whatever given, will be neutralized and the bleeding continues. If you have a high titer, that is greater than 5 Bethesda unit, and this patient will have to be given bypassing agent. On the other hand, if you have a low titer inhibitor, and if he's got a high responder, that is, antibody increases after factor 7 infusion, that's an anamnestic response, this person will also have to be given bypassing agent. There's no other choice for this patient. On the other hand, if you have a low responder, that means that there is no elevation of inhibitor titer after giving factor VIII. He's a low titer inhibitor, and therefore this patient, you can give a little higher dose of factor VIII and manage the surgery. So what is the meaning of major and minor surgery? Major surgery means an invasive procedure where you actually invade a body cavity, you cross a mesenchymal barrier, or you cut across a facial plane, or an organ is removed. That basically a normal anatomy is operatively altered. And these type of surgeries, you expect it to take treatment for at least more than 7 days or so, and that is a major surgery. On the other hand, if you look at a minor surgery, what is meaning? The meaning is only mucous membrane like oral cavity or skin or superficial connective tissue was manipulated, like for example, dental tooth extractions or endoscopic surgeries, or endoscopic evaluation and so on. And here you don't expect the surgery to, the treatment to last for more than 7 days. So that is the meaning of minor surgery. So just to understand that what is major surgery, what is minor surgery. So when you actually look at patients who you actually consider for, say, elective orthopedic surgery in patient with hemophilia and inhibitor, you have to look at the relevant comorbidities the patient has got, his age, his inhibitor titer, and whether the hospital has got an experienced and multidisciplinary team, and the type of urgency of the surgical procedure. Now, these are all important because depending on the type of surgery, what the patient and the family prefers, and the risk factor for thrombosis. The other issue that you have to decide also is, because all these will determine the cost of replacement of bypassing products is horrendously costly. Like I told you in the previous slide, you have to depend on NHM, World Federation of Hemophilia, Hemophilia Federation India, third-party insurance, and so on. So these are all the things that you have to consider. And of course, in your stock, you should have adequate supply of replacement factor or bypassing products, and you should have both, either FIBA or Nova 7, both of them you should have just in case you land up in a surgery. And then of course, timing of surgery. Timing of surgery also is important because you ultimately, if it's elective surgery, you have to plan it preferably in the beginning of the week, that is Monday or Tuesday. You cannot have a person with hemophilia and more so a patient with inhibitor to have a surgery somewhere in the weekend, where the hospital systems are not very optimal, and therefore it's preferable to have surgeries in the early part of the week. As also the timing, in the sense that how emergency surgery and whether you can optimize the products that are there in your stock by postponing or preponing the surgery is all important. So how do you assess the patient for hemostasis and person's hemophilia? You look at the CBC and look at specifically the platelet count. You look at drugs that the patient may be taking, whether they've got an antiplatelet effect. You look at the plasma clotting time, APT, TPT, factor VIII, factor IX, and whether the person has got inhibitor, fibrinogen levels. You can also do response recording. We do that sometimes, where you give factor VIII or factor IX at about 30 to 50 unit per kg, and then we see how much of factor is recovered. And based on that, you can probably calculate what factor you need for him on day 1 of surgery and a couple of hours into surgery, and then post-op how you manage. So this is somewhat of a rough guide. Then of course you have to look at the viral status, whether the person has got HIV, HBV, HCV, and also what type of anesthesia I would give for surgery, whether it's general anesthesia. And we would normally recommend general anesthesia, and you also would recommend to give tranexamic acid unless otherwise contraindicated. We give normally at about 25 to 30 milligram per kg every 6 to 8 hours. Then the types of surgeries. So if you are actually trying to see whether you can have a reduction in the bleeding frequency and you want to do a synovectomy, you can do either radioactive synovectomy or a surgical synovectomy. If you have contractures, you wonder whether you have to do an extra articular soft tissue release, and that is a different type of surgery. If you do arthroscopy, it's basically to diagnose and correction of adhesions or impingement within the joint. If you have angular deformities, then you want to know whether osteotomy would be beneficial. Arthrodesis of the ankle, where is surgical immobilization of damaged joint. So these are the procedures that you can normally do in orthopedic surgeries, and the purpose of doing these type of surgeries. So what are the interventions that you do in a patient with chronic synovitis? You can do synoarthritis or synovectomy, which could be radioactive. In a person who's got a fixed flexion deformity, they can do tendon lengthenings, external fixators, extension osteotomies. In a person who's got a destroyed joint, you can arthropathy. You can do a joint replacement. You can do nerve releases. You can do curettage of the bone cysts, joint debridement, alignment osteotomy, arthrodesis, so on. Patients with HIV, especially if you have, then all these things have to be taken into consideration, because this has to be intensified, because post-surgical surveillance due to increased risk of infection is a major issue. So you have to be careful when you operate patients with any of the viral infections. So normally what do you do in a patient who's got hemophilia inhibitor? You do an ITI. The idea is to eradicate the inhibitor. You can do prophylaxis. The idea is to prevent bleeding episodes. And then, of course, whenever the patient has a bleeding, you can give on-demand treatment. These are the common strategies that you adopt in a patient who has got inhibitor. But when you have to have surgery, okay, none of these products, either Emicizumab or Consumab Fusran, can be used, and only you have to have recourse to is the bypassing agents. So what are the bypassing agents commonly available with us? We have either FIBA or NOVO7. FIBA or NOVO7 can be used effectively to control bleeding episodes. It is used in perioperative, intraoperative, and postoperative management. It is also used for routine prophylaxis to prevent bleeding frequencies, especially also after rehabilitation. And then, of course, prophylaxis and managing breakthrough bleeds in cases of ITI. So these are common uses of FIBA, but in the context of surgery, it is perioperative, routine prophylaxis during rehabilitation, and then managing the breakthrough bleeds. So let us look at each of these products and see how we use them. So what is FIBA? It is a mixture of prothrombin, factor 10, factor 9, factor 8, and there are other coagulation protein factors that are natural anticoagulants that are there in the body. So what happens when you give this FIBA to patients IV? So it acts both on common pathway, it acts on extrinsic pathway, and it acts on intrinsic pathway, and therefore produces a stable clot. There are also these anticoagulant, natural anticoagulants, which are protein C and protein S, which sort of prevents thrombus dissolution and therefore forms a stable clot. So this is a product that you can combine, works on all the three pathways: intrinsic pathway, extrinsic pathway, and the common pathway. What is NOVO7 or factor 7A, activated factor 7A? This is a factor that is got activated factor 7, and when you give this infusion, what happens is that it both acts on the common pathway and in the intrinsic pathway and produces stable clot. So the advantage of this is that you have a tissue factor. Whenever there's a vascular injury, the tissue factor is exposed. Factor 7 activates factor 7A, activated factor 7A, stimulates thrombus and platelets, on which is factor 7 activate and produce a thrombin burst. And this localizes the thrombus to a place where there's vascular injury, and it closes the clot and forms a stable clot, because this forms a tight, stable fibrin plug and is less prone to being dissolved by normal fibrinolytic systems in the body. So this is how NOVO7 or factor 7, activated factor 7 acts. So in summary, if you look at FIBA, you would look at NOVO7, and you look at the new kid on the block, Hemlibra. For surgery, only two, FIBA and NOVO7. FIBA has been used for more than 40 years or so, and NOVO7 has been used for more than 20 years. Hemlibra, we have got to use only for the past 3-4 years, and the experience is limited. And I will speak also on the Hemlibra and how we have used it in managing patients with hemophilia, in patients inhibitor and hemophilia. The half-life is about 4 to 7 hours in FIBA, very short in case of NOVO7, very long in case of Hemlibra. Infusion time takes a long time for you to infuse FIBA. Nova 7 is just a shoot, it's just a bolus given over 2 to 5 minutes. Hemlibra is not given IV at all, it's used subcute. So it's very convenient to have Hemlibra around when you are planning surgery in patients with hemophilia. Now, surgery is very challenging in hemophilia with inhibitors because it is very difficult to maintain intraoperatively, postoperatively, and throughout the physiotherapy portions, especially for orthopedic procedures, very difficult to maintain good hemostasis. And if you are having a high titer, that's more than 5, the standard replacement cannot be given in sufficient quantities to overcome the inhibitor control during the surgery and after surgery. And many key studies have showed that FIBA, that BPA, bypassing agents, effectively controls bleeding in large majority of patients, 78 to 100% in major surgeries and 75 to 100 in minor surgery. So it's a challenge to treat patients with high titer inhibitor and hemophilia. So how do we give FIBA during surgery? Pre-op assessment, you look at the clinical, you look at the functional and quality of life, you look at the surgical procedure, what surgery you're actually doing, and what is the critical nature of the surgery that happens, whether nerve release or whether you can manage to have a small clot. Because if you're handing a nerve, even a small clot can cause paresis, and therefore you should be careful as to what type of surgery you're contemplating. And this is a constant discussion that you have to have with your orthopedic colleague, time of surgery, how long he's going to take to do that surgery, how long is the anesthesia time, so that you can plan your factor replacements on. So when the surgery is done, you look at monitoring for efficacy and safety, and you can tell the surgeon that you tell me in your surgery within an hour or so whether your expected level of bleeding is normal or it's more than normal. So if it is more than normal, during the surgery, you shoot another shot of bypassing agent, whatever you have, and then take up surgery. So this is a constant interaction that you have to have with the surgeon to see that ultimately there's a good clinical response, and then you can take the patient further for rehabilitation. Now, supposing there's a poor clinical response, you have to adjust the dose, increase the dose, and if there's a failure, whatever dose you're giving of the bypassing agent is not correcting, you have to have the alternate use. Either you can, if you're using FIBA, you use Nova 7, or if you're using Nova 7 upfront, you have to change it to FIBA. So that is the general plan. And you can look at the dose that is given for major surgery, 75 to 100 unit per kg that is given. And we normally use about less than half the dose, 30 to 40 unit per kg. But here we use tranexamic acid. In day 1, we give about 30 to 40 with tranexamic acid, whereas the recommended dose is 75 to 100 units eighth-hourly. By day 8 or 21, after the surgery and after the storm is over, you maintain much lower dose, but this is you give twice a day or so for the next 2 weeks or so. And you can even reduce it depending on how good your hemostasis has been, how good the activity has been, the pre-operative state of the patient. Then you can probably taper on to give daily for 1 week, and then every other week, every other day a week, things like that. So you have to play by word of mouth after you put the patient on rehabilitation. So this is the FIBA dosing. I've given you both the recommended doses and what we actually use in our practice. When you come to Nova 7, activated factor 7 of surgery, here it is a little costly, and you preoperatively give 90 units per kg every 2 hours. But what we do normally is about 30 to 40 microgram per kg with tranexamic acid. On day 1 to 7, again, we go down much lesser, 20 to 30 microgram per kg plus tranexamic acid, whereas the recommended dose is something like 90 microgram per kg. This is you give it for about a week or so. After a week, again, you taper like what you did for FIBA, and you taper it over a period of time so that the least amount of factor, that bypassing agent that can be given is comfortable, the patient is comfortable with. Again, when you give FIBA, when you give Nova 7, and the success is not very good, I mean, in the sense that there's more frequency of bleeding, then you have to shift to an alternate pathway, that you have to shift to bypassing agent. I mean, to shift to FIBA. So if you're using Nova 7 upfront, and there's no good response, there's a failure of response, then you shift over to FIBA and vice versa. The third product. In the Haven 1 to 4 studies, when they did surgeries during that period of time when the patients were on trial, they've done something like about 233 surgeries in Haven 1 and 4. In those surgeries, you can see that both major and minor surgery, when you take minor surgeries, they were managed without prophylactic coagulation factor, whereas when you took major surgeries, they have to use prophylactic factor, and approximately the amount of factor bypassing agent that you use, or the factor standard factor 7 or 8 or 9, much lesser when you compare. So in conclusion, what we have to do is, when you after surgery, you have to have a good physiotherapy and should ensure a good surgical outcome. Post-surgery physiotherapy is very important to maximize the range of motion. Continuous passive motion is an early post-op period under cover of bypassing agent, and a pre-training bolus of BP is recommended before physiotherapy session and after discharge. Now, sometimes what happens, there's an unexpected bleed. If oozing persists after surgery, check the bolus dose have been given as prescribed, because sometimes you miss the dose, and then you stop rehabilitation program immediately and rest the limb. Check the coagulation screen, platelet, fibrogen. Bring the next dose forward. Instead of giving it 8th hourly, make it 6th hourly. Consider increasing the dose. And if the patient has developed thrombocytopenia for whatever reason, you have to give treat that patient with platelet transfusions maybe, and consider changing treatment to an alternate bypassing agent. If you are giving Novo-7, you could change to FIBA, or giving FIBA, change to Novo-7. So presence of inhibitors increases the risk of uncontrolled bleeding and disability and premature death. Awareness and clinical suspicion and prompt laboratory investigation is critical to establish the diagnosis. Bypassing agents are a cornerstone of these patients, and there's a need for effective protocol, product, risk of infection, and so on. And that is the basic features or facts of managing patients with hemophilia.
Thank you, Cecil. That was a comprehensive lecture. Hello.
Yeah, tell me.
Hello.
Yes,
So I think one of the things we also need to stress is that as far as surgery in hemophilia is concerned with inhibitors, it's best to avoid it unless absolutely necessary.
Absolutely.
Or you have a lot of money.
Yeah, absolutely.
Yeah.
Because the kind of monies and the
now
kind
there
of
are two
products that you
questions.
use.
Yeah. Correct. It's huge. Yeah. That's right. So there are a couple of questions not related actually to your lecture, in spite of my repeatedly telling people to ask questions related to the lecture. But anyway, if a child is using Emicizumab from the beginning, then is there a possibility that he may develop inhibitors to Emicizumab? Anyone wants to take this? Yeah. Tell me, Cecil.
Yeah, I think it is possible. You have anti-drug antibody that develops in a certain percentage of patients, but the incidence is very low. You can develop.
Okay. Can we use Tranexa with Emicizumab?
We have used tranexamic acid with Emicizumab in a patient who had intracranial bleed, and we did not have much of FIBA at that time. And we have used it without much of a problem. This patient had, I mean, this is all anecdotal, and the sense this patient had intracranial bleed, he had inhibitor, and then he was on Emicizumab on compassionate grounds from Roche. And when we gave him, and when he had developed the intracranial bleed, we had to do surgery. Then he developed, then we found out that he had intraventricular abscess, that is pus coming out from the ventricles. Then we had to give him heavy antibiotics. At that time, we had to give him only little bit of FIBA, that is about 1,000 units every day, along with tranexamic acid. And this patient was there in the hospital for 3 weeks. We had to put an external ventricular device a couple of times. And despite all that, the patient did not make it, but he was there in the hospital, fluctuating for 2-3 weeks. And no time we had, giving low dose of FIBA, we had a bleeding complication. All his complications were infection related, hydrocephalus, fever and things like that, but nowhere ever there was a bleeding. So it is possible to use tranexamic acid, a little bit of FIBA on the background of Emicizumab.
Right. Is there an increased chance of developing a thrombosis in such patients if you were to add the Tranexa, theoretically?
Well, this patient was in ICU. We gave him low dose heparin.
Oh, okay. Oh my God.
Yeah, we had to give, because he was in the ICU for 3 weeks, three months. He was in the ICU for 2-3 weeks, in and out of ICU. Whenever he was in the ICU and he was altered sensor, we had to give. The moment we put an external ventricular device, he would be awake and he would come to the ITU, and then again the hydrocephalus would increase. Then we had to adjust the dose of the external ventricular device, and then he would again lapse to coma. So during the time when he was in coma and all that, we had to give him tranexamic acid, bypassing agent, and while he was on Emicizumab once a week, and managed him.
Oh my
But I tell you that we never had a bleeding problem with this guy. Bleeding is not an issue with this guy. His only problem was infection and pus in the CSF.
Right. There is one question. I think I'll just comment on it. I am a patient with factor IX deficiency, severe hemophilia. I was positive in the first week of April. I presume that is for COVID. And given heparin and aspirin during treatment, was it intentional to use such drugs during treatment? So, Mr. Sharan, see, first of all, I keep saying, please ask questions relevant to the lecture. However, what I would like to comment, and this is for all patients, is that if you are a hemophilic and you develop any other problem, please inform your treating physician that you have hemophilia, that it's a bleeding disorder, and that you tend to have spontaneous bleeds. Because very often physicians are not aware of this particular condition. After that, the way they treat you will depend on the discretion of the physician. We are in no position to comment on whether the use of the drug was intentional or required or not, because we are not there treating you at that moment. It is always best that the physician treating you in a particular moment decides what treatment you should be given at a particular time. One more question, Cecil. If a kid starts Hemlibra and then stops after a few years for financial reasons, what is advised after that?
You can go back.
Then you go back to the treatment of
Yeah, I think you can go back. I mean, it's also advisable in the sense that when you're a small child, you give Emicizumab, and for financial reasons, you have to stop the Emicizumab. At least about time, the veins would have developed. Your child can be more comfortable taking prophylactic at least twice a week, normal factor 8 or factor 8, and probably it's okay, I suppose. No issue at all.
Sure. Right. So with that, thank you, Cecil. We come to the end of this particular lecture.
Actually, yeah. Sir, are you using injectable tranexamic acid or oral tranexamic acid along with FEBA, Novosin, the small dose you are doing for surgery, major surgery also, na?
We give IV.
Give IV, sir.
IV. You see, because the amount of FEBA that we have is hardly any. 500 units and 750 units, 1,000 units when the patient on Hemlibra. So I think we are comfortable giving IV.
Yes. After sir, you were commenting something. Yeah.
No, we recently had a patient, two brothers who are on Hemlibra post-trial access. They had an accident. One brother had a subdural bleed, but he was Glasgow coma scale was 15. Neurosurgery said no intervention. We did not give him anything, and he fell through. The other brother had hepatic tear, renal tear, bilateral renal tears. So we managed him only on him. We had only 18 milligram of Novo 7. We just used it in first day, and we just managed him with IV tranexamic acid. He was in the hospital for 3 weeks. He was on low molecular weight heparin prophylaxis, and he was on a weekly 1.5 milligram kg of Hemlibra, and we continued that. And he fell through. He was there in the hospital, but IV tranexamic acid with Hemlibra, I think that saved him, because we didn't have much fever or Novo 7. We are sending this as a case report because he underwent 5 surgeries in 3 weeks.
Oh, wow.
No fever, no Novo 7 was used.
Right. Okay. There is one more question, again, not relevant to the lecture, but we'll quickly take it. A person with hemophilia has hematuria. What is the safety of use of tranexamic acid? Dr. Karim, we do not recommend the use of tranexamic acid in patients with hematuria, because you may go into a acute kidney injury, you may develop with that. So by and large, I would avoid the use of tranexamic in hematuria. Anybody wants to add anything to that? Right. So with that, we'll come to the end of this particular lecture, and Chandrakala, you can take over for the next.
Yeah. Yes, madam. Yeah. So the next lecture is on it's a very important topic. Every time we face patients coming, and then even the doctors are facing this issues. It's von Willebrand's disease. How do you manage menorrhagia and pregnancy? Now that we have factors and patients are also leading the lecture, they're reaching adulthood and there are pregnancy also. We have got many patients who is pregnant and VWD. So we have Dr. Shashikant Apte sir. He is the head and Department of Hematology and Bone Marrow Transplant, Sahyadri Hospital, Sahyadri Specialty Hospital, Pune, and is also Vice President Medical HFI now. And sir, over to you, sir.
Thank you, Chandrakala. Thank you for giving me this opportunity. Thank you for giving me this opportunity. I thought you are taking some kind of conspiracy against me because it's one of the most difficult topics. What has happened?
So that's why we are giving it to you, sir, actually.
It's a real difficult topic, but yes.
Very important topic.
Very important and very difficult topic.
Yes.
I think my slides are opening. It's a nightmare, actually. It's a nightmare. Yeah. Can you see the slides now? Can you see the slides?
Yes, sir, we can.
Fine. So I thank Chandrakala and Farah for giving me this topic because I had to read it again. I had to try to make out something to talk for 20, but it's a very, very important topic and most nightmare to manage these patients. I'll just share the data. This is the NHR 2020 data. We have only 812 von Willebrand disease patients registered in the registry as compared to the hemophilia A and hemophilia B patients. But we must understand that von Willebrand disease is the commonest congenital bleeding disorder. And many times, type 1 von Willebrand disease is missed, and the child who attains menarche, the bleeding doesn't stop. Lot of time is delayed by the gynecologist, not knowing that this could be type 1 von Willebrand, which is presenting as a menorrhagia at the time of menarche. Menstrual phenomena is a physiological hemorrhage, which gets complicated due to congenital bleeding. And we have to pull out these people at least for 3 to 4 decades of their life and not to go into shock or not to land up in major bleeding complications. And carrying von Willebrand, especially type 3 patient through pregnancy and delivery is a challenge. I'll just quickly go through. We have to, once we make a diagnosis of probable von Willebrand, we must try to identify what category of von Willebrand disease it fits in, because the guidelines of management options are different. And there are 10 to 12 labs in the country now very regularly doing von Willebrand studies. We are not doing multiple analysis and PFA 100 tests, but other tests are done in our institute. KEM Mumbai is doing it, Vellore is doing it, Bangalore, St. John's is doing it. But we have to have a correct diagnosis and a subtype of von Willebrand disease. And we know that these are the basic subtypes now, which have been understood for von Willebrand disease, which is quantitative deficiency and qualitative deficiency. Majority of our patients, diagnosed patients, are type 3 patients. Majority of the times, type 1 patient may be missed, which has a partial quantitative deficiency, and type 3 has a virtual complete deficiency of von Willebrand. And then there are type 2, which is divided into A, B, M, and N, which can be deciphered in majority of the labs if they are doing regular von Willebrand management. So first and foremost, we have to once identify the patient with von Willebrand disease, we have to apply the I stage bad score and split them into mild, moderate, and severe. Because some of the von Willebrand disease patient will only have menorrhagia, whereas some of the patients will have major bleeding from nose, GI tract, urinary tract, skin ecchymosis, or even IC bleeds. And depending on the primary severity of a category of von Willebrand disease, we have to add the menstrual bleed and management of menstruation in the given lady. We have a lot of treatment options for von Willebrand menorrhagia. Now factor concentrates are available. There are plasma-derived products, and now we have recombinant von Willebrand factor available. Desmopressin is available. Tranexamic acid has remained the cornerstone in the management of this therapy, or management of menorrhagia. And hormonal preparations, electroablations, intrauterine devices, and with hormones. And obviously, the last resort is hysterectomy. When Farah and Chandrakala asked me, when I started looking at it, luckily in January 2021, ASH, ISTH, NHF, and WFH came out with the guidelines for management of von Willebrand disease. And it's an excellent article, excellent document to have with it. And my majority of the slides I have prepared from this document. World Federation has prepared the guidelines on management of hemophilia, and similar effort has been done by ASH, ISTH, and WFH to come out with these guidelines. So there are two types of recommendations that they have compared. That is a strong recommendation, and there, wherever it's a strong recommendation, the wording uses panel recommends. And when it's a conditional recommendation, it says that the panel suggests. So these interpretations of strong and conditional recommendations have four perspectives: a patient perspective, clinician perspective, policymaker perspective, and researchers. And I won't go into the details, but it's a very interesting article to read and try to understand how the guidelines are prepared. So coming to the first recommendation is prophylaxis. Today, everybody talks of prophylaxis in congenital bleeding disorder. Definitely, they say all type 3 von Willebrand patients with severe and frequent bleeds, the panel suggests using a long-term prophylaxis rather than no prophylaxis. In our country, we have recently started prophylaxis for factor 8 and factor 9 deficiencies. I don't know whether any patient is on dose or any patient is on regular prophylaxis for von Willebrand disease. But if you have to prophylax von Willebrand disease, the dose recommended is 40 to 80 recof activity units per kg per week. You can give it as 2 split dosages. Even single dose has been shown to be effective in reducing the total number of bleeds. And definitely the amount of bleed in person who has attained menarche has definitely come down. So people are recommending you can have on-demand factor at this dose during the period of menses, and you may not go on a full-fledged prophylaxis. And the dose is same for plasma-derived or recombinant von Willebrand factor. Then second major drug is desmopressin challenge or a trial. And they have very clear-cut guidelines that if the primary von Willebrand level is less than 30%, it is very important to give a trial of desmopressin rather than straightway using it in the setting of acute major bleed. If it is more than 30%, there is no need to give the trial, because it is assumed that if your von Willebrand baseline levels are above 30%, irrespective of your blood group, if you give a desmopressin challenge, they will respond. And that also becomes a good option for patients with von Willebrand disease who are going to get cyclical menorrhagia, and they can be ready with the use of desmopressin in the setting of menorrhagia. And dose of desmopressin is 0.03 microgram per kg given over 30 to 60 minutes. But it has to be supported with saline infusion. There are certain remarks regarding desmopressin, and care has to be taken in all the patients. Desmopressin is contraindicated in type 3 von Willebrand disease because there is a complete absence of the factors. Many patients with type 2 von Willebrand disease do not respond to desmopressin, and they require other modes of treatment. But desmopressin trial in this setting may be helpful to confirm and may help in some of the type 2 von Willebrand patients. Adult patients with type 1 von Willebrand disease where factor levels are more than 30 IU per DL at baseline can be taken as desmopressin responsive, and they can be given desmopressin in each cycle, each menstrual cycle. And they can develop a refractoriness, and there could be a period where the desmopressin may not work and you will have to add other things. Patient with type 1 von Willebrand disease less than 30 units, may not respond to desmopressin, and you may have to keep these other products available, especially the factor. And hyponatremia management is very crucial, and saline support is required. There are definite contraindications for desmopressin. That is type 2B von Willebrand disease, coronary artery disease, any patient who has had a stroke or a seizure disorder, it should be avoided. Type 1 von Willebrand disease, for surgical situation, desmopressin should not be used. If pregnancy has preeclampsia or is going to receive oxytocin drug like pitocin or has multiple pregnancies, there is a strong contraindication for desmopressin, and desmopressin should not be used as it can worsen the life or can cause issues, especially in the setting of pregnancy. When there is a heavy menstrual bleeding, there is a strong recommendation to use hormonal therapy with tranexamic acid over desmopressin. Because strong menstrual bleeding requiring blood transfusions, we have to consider two situations. That the lady doesn't want to conceive, or she has completed family, or she wants to conceive. So when the lady doesn't want to conceive, hormonal therapy becomes the easiest mode. But sometimes we had a couple of patients that they lose control over hormonal therapies, and we had to do electroablation, uterine artery embolization. And ultimately, one 19-year-old girl, we ended up doing hysterectomy because she virtually died 4 or 5 times because of massive menstrual bleed, was brought in shock, was on ventilator twice, and everything else had failed. We had done everything. In heavy menstrual bleeding, the regular use of tranexamic acid, 25 milligram per kg into 3 times a day for at least 7 to 8 days, has definitely shown the benefit in these patients. On demand, if you use tranexamic acid, a person is on hormonal therapy and still bleeds, we can use 20 units of von Willebrand Bikoff assay factor 1 per kg once a week till the bleeding stops. So the patient may require product over 4 to 5 days, but when it has been used in this fashion, there is around 3 to 4% incidence of developing inhibitor to the von Willebrand factor, and it can create an issue. Because managing von Willebrand factor with inhibitors, we don't have great experience. We do not see many patients, but you may land up with this situation because it's an intermittent exposure to the product. And patient will definitely need multiple therapies. In these patients, they are very prone to iron deficiency, and they should be on really long-term oral supplement of iron replacement. When there is a lady with heavy menstrual bleed and type 3 von Willebrand disease, a multidisciplinary approach is always required because they are not going to ever get control. They are not going to be happy. So there has to be joint efforts from the OBGY team and the hematology team. The use of intrauterine device with hormones should be very carefully done in the setting of whether the lady wants pregnancy, doesn't want pregnancy, because intrauterine device with hormones, the incidence of secondary infertility is fairly high, and they may have real issues with getting pregnant once these episodes are over. The treatment of menstrual pain, management of endometriosis and polycystic ovary has to be kept in mind. Always it is important that every bleed in a congenital bleeding disorder person is not because of the bleeding disorder. Make sure there is no local uterine or pelvic pathology. A regular examination by OBGY team and a regular ultrasound at least once in a year is required in patients with heavy menstrual bleeds. Once the person has crossed age of 35 years, we have to keep in mind the other adverse effects because of hormones leading to endometrial hyperplasia, malignancies, especially in patients who have polycystic ovarian disease, who have high body mass index and obesities, and diabetes and hypertension. These 3-4 things which are controllable, we must be very aggressive in managing diabetes, hypertension, obesity, and polycystic ovarian disease, because unless you tackle them, the bleeding keeps worsening despite trying to do everything, and patient may land up with an early hysterectomy rather than late hysterectomy. Coming to the pregnancy, there are 3 issues when a pregnant lady A 1 milligram lady wants to conceive pregnancy, you have to really have a good counseling with the family and the patient. There are the issues with anesthesia, route of delivery, and postpartum management. Majority of the deliveries, whenever required anesthesia, are under neuraxial anesthesia, either epidural or spinal anesthesia. When you are giving a neuraxial anesthesia, you should maintain the von Willebrand Rickoff assay or factor VIII assay between 50 to 150 IU per DL. This is like a small surgical procedure because you are going to use a needle. You may be expert in giving spinal or epidural anesthesia, but there could be a surgical bleed. And surgical bleed in spinal region can be very, very catastrophic. And you have to maintain the level before you give spinal or epidural anesthesia. For general anesthesia, the recommendation is same. You maintain the level between 50 to 150 IU per DL and then start with the anesthesia. Because if you are choosing general anesthesia, obviously the delivery is going to be more complex, more complicated. And you may have a surgical intervention needed for the delivery. Now coming to the route of delivery. The route of delivery has to be decided by the OBGYN team as per the indication, stage, and at the what period of pregnancy weeks the delivery is occurring. Hematologist is just going to support the OBGYN decision. Forceps and vacuum deliveries are to be avoided because they can cause a surgical injury to the mother as well as to the child, and you do not want that. So generally the preferred route is normal per vaginal route. If there is any issue with the per vaginal delivery, better to do the LSCS because it is far more controlled surgery and far more controlled setting you can carry out the procedure. Von Willebrand disease should not impact the decision regards the route of delivery. The factor replacement has to be kept around 150 IU per DL. Always avoid levels to cross of factor VIII or Rickoff assay about 200 IU per DL. But once you start crossing 200 IU per DL, there is an extreme increased risk of thrombosis. Pregnancy itself is a thrombogenic situation. Multiple pregnancies, twin pregnancies, pregnancies with preeclampsia, there is a very high risk of thrombosis in a postpartum period and immediate peripartum period. LSCS has to follow a major surgical replacement protocol during the surgery and till the wound healing is occurred. And these are the protocols recommended by this committee. So you can see the major surgery protocol, daily dose of 50 to 60 IU per kg of von Willebrand to maintain the factor VIII and Rickoff levels between 100 to 80 to 100%. And then to post-operatively maintain 50 units, there is a typo error, until the healing is complete, usually 5 to 10 days. Measuring plasma levels of factor VIII and Rickoff assay every 12 hours on day of surgery and then every 24 hours is mandatory. Because post-pregnancy, postpartum period is a completely dynamically different period than a non-pregnant person. We cannot have the same PK/PD of the von Willebrand factor that we have infused in a pregnant person and non-pregnant person is completely different. And a very strong recommendation is to use LMWH as a prophylaxis in patients with high risk of venous thrombosis. During the delivery and puerperium, daily dose of 50 IU per kg of von Willebrand factor to maintain levels around 50 IU per DL for 3 to 4 days. And 4 to 5 days is good enough because the placental area, the uterine area would have healed in 4 to 5 days time and you can stop the factor. All along, you continue tranexamic acid, IV or oral, whatever is available. Desmopressin is contraindicated. Desmopressin is not, injectable desmopressin is not routinely available, and nasal desmopressin has a very erratic course, and we cannot depend on nasal desmopressin. But during pregnancy, it is best to avoid desmopressin. In postpartum period, we have to keep levels up to 50 IU per DL for 7 to 10 days, and tranexamic acid is continued 3 times a day for 10 to 14 days. A normal breastfeeding can be immediately started for the child, and there is no contraindication to breastfeed the child. So there are a lot of remarks regarding pregnancy and delivery in this guideline statement. Individual risk assessment has to be performed. We cannot have a simple algorithm for delivery of a type 3 von Willebrand disease person, 10 persons will follow 10 different routes. And they strongly advocate, and which we also been doing, that as soon as 32, 34 weeks are over, we assess what is the factor VIII and von Willebrand activity. Because some rise in von Willebrand factor may happen even in type 3 patients, and you do not want to cross the 200 figure for the risk of thrombosis. Von Willebrand activity should be maintained around 50% while epidural is in place and at least 6 hours after removal of the epidural catheter. Von Willebrand levels in a postpartum hemorrhage have to be monitored. And von Willebrand activity, if there is a setting of PPH, you have to keep at around 150 IU per DL. With other monitoring of plasma fibrinogen, thrombin time, because they can land up with DIC in PPH, and you should not miss DIC in this setting. If there is an excessive bleeding post-delivery, it may not be only von Willebrand disease because you are maintaining levels. If the levels at around 150 IU per DL and patient is bleeding, there has to be some surgical cause. And as I said, the anesthetist and OBGYN decide the route of anesthesia and route of delivery. Strict monitoring of the levels are required for first 5 to 7 days, and immediate LMWH should be started for patients who are at thrombotic risk. And tranexamic acid is continued for 14 days. So in conclusion, to manage any lady who is diagnosed at 5 years, we have to counsel the family, the patient, that it's a long story, it is going to be a long affair, mentally prepare them. The female patients with type 3 von Willebrand disease is always a challenge. And a lot of individual variations needed in approach. No two type 3 von Willebrand disease patients behave in the same fashion. Von Willebrand type 3 should undergo delivery at a proper center where there is a proper setup. It can create a disaster and you may lose a life because of excessive postpartum hemorrhage. And other causes of bleeding post-op should not be missed. Here I would add, because majority of the now factor is coming from the government setup. And generally I have been seeing that there is a tendency to procure 100% recombinant factor. If you procure 100% recombinant factor, you will not be able to treat your von Willebrand patients. We must have some von Willebrand containing factor, and at least substantial amount should be made available for these patients, and von Willebrand containing factor should be available. Recently, Ms. Chandrakala has, we had discussed this with Chandrakala, we have put one girl on low dose Hemlibra, 3 milligram per kg once a month. She has had last 6 months, and really it has worked wonders. And she was a heavy menstrual. She has required so far around every menstrual cycle, she used to end up having at least 2 or 3 transfusions. She's a 15-year-old girl now. She attained menarche 8 months back. First 2-3 months were horrible. We could get some compassionate Hemlibra, and we don't know how this Hemlibra will change the course in type 3 von Willebrand disease. But theoretically, I feel it should work. If it is working in severe hemophilia A without inhibitors and with inhibitors, I don't see any reason why it should not work in type 3 von Willebrand. Thanks for your kind attention. Thank you, Chandrakala and Farah.
Thank you, sir, for a wonderful lecture and sharing your experience on a very really topic and really difficult topic, and difficult in the clinical management actually. So when the patient comes and bleeding, actually it becomes very difficult because they require transfusion after transfusion. So we have few questions, sir. One, first we'll take up from Dr. Neeraj questions. He's asking, how do you calculate the increment after CFC replacement in VWD? And what is the half-life generally you consider? And can factor VIII be used as a surrogate marker for VWF?
We are using factor VIII as a surrogate marker for when we are operating for type 2B. And because we don't have multimer analysis done, and we also monitor the platelet count. But primary monitoring is done with factor VIII assay for this type 2B.
So how do you calculate the factor replacement, CFC replacement? Do you calculate on the factor VIII? Because some of the factors has got 1:2, one of them has got, some of them has 1:1 proportion. So how do you calculate, sir?
No, if you saw my slide, you should calculate, because every factor bottle, they are given von Willebrand activity. So you should start with 40 to 80 units per kg So you calculate with that, and then you will see that we have done this exercise, and generally you don't cross the factor VIII levels above 200%. And you have to keep in mind what is the blood group. What is the blood group? Very important.
Yeah. And he asked the same thing again regarding what you just mentioned, the surgical management of type 2B or platelet type VWD when molecular support is not available. So how do you manage that? What you just covered that?
Yeah.
So we have other questions. Dr. Subhashish, the stats say prevalence of VWD is high. Why NHR data is so low?
See, majority of them, Subhashish, the von Willebrand disease is missed. See, the commonest type of bleeding is type 1 von Willebrand disease. And it may be passed as a minor bleed. And that's why we do not have much data. And another thing, in our country, I don't know how many, I don't think more than 10 labs are totally geared up to make a diagnosis of von Willebrand disease. It's a lack of diagnosis also. And I think that is the major reason why we have not reported much von Willebrand disease in our NHR with HFI.
The next question is, can VWD patient use factor VIII or vice versa? Can a PWH use hemate P factor?
See, hemophilia A patient can use von Willebrand containing factor VIII, but von Willebrand patient should not use pure factor VIII. If you use high purity plasma derived product which may not have von Willebrand factor, will be useless for a patient with von Willebrand. Intermediate purity von Willebrand can be used by both. A recombinant factor VIII will be only used by hemophilia A patient. It is of no use to von Willebrand patient. And now we have recombinant von Willebrand factor, which is of no use to hemophilia A patients.
So it's regarding the desmopressin, sir. This is from Dr. Mona. The nasal spray for desmopressin available in the market is Mindrin that has got 0.1 milligram ml concentration. So how do you use in VWD type 1 actually?
We don't use. We did a long back and we have published that data. It is extremely erratic. The absorption is extremely erratic. When you are especially doing a small surgical procedure, you can't keep waiting for the factor access to come, even say for simple dental extraction. You can't wait for 4-5 hours to get this nasal desmopressin to act. Injectable desmopressin is far more predictable. But for last 17-18 years, for some reason, injectable desmopressin is not available. So if we have a minor surgery or a major surgery, we purely rely on factor VIII, von Willebrand containing factor, and we not use desmopressin for last 16-17 years.
Chandrakala, can I?
Yes, sir.
Sure,
Yes.
sure.
Yes, sir.
See, in nasal desmopressin, nasal spray desmopressin is very useful in women who have menorrhagia. So what I normally tell them is you take the tranexamic acid. If they don't respond well, you can actually tell them the day before, if their periods are normal, the day before surgery, take a nasal spray, one spray in each nostril, twice a day or thrice a day for 5 days during the period. After that, stop it. So the menorrhagia seems to be coming well under control with nasal spray. Otherwise, nasal spray is not much useful in many other situations, except in patients with menorrhagia and they bleed in their periods.
Sir, continuing that answer, sir, the spray available in India is the concentration is very low, but the concentration it's recommended for the VWD is 150 microgram per spray should be there.
Correct.
So do you use the whatever is available in India that you use, sir?
That's what we use. That's what we do. You just take the day before surgery, the day before periods. If she knows that she's going to get the day period on that particular day, you start the prophylaxis with that nasal spray twice or thrice a day, and then you continue till the end of period, and then you stop it. Otherwise, what happens also, they develop tachyphylaxis with that spray. So, so you just have to use it. It will not help too much, but many people say that it has been useful in the sense that their periods have been near normal, if not heavy. But you also use tranexamic acid with
that. Yeah.
Or would you do the levels before the surgery, Cecil, if it's a minor surgery? Factor VIII and recof acid?
No.
So we'll take one more last question. Treatment of a young girl with heavy menstrual bleeding wants to conceive. So how will you manage? That's actually they want to know. Dr. Mustafa Kareem. Yeah.
See, if they want to conceive, I showed it. The we should avoid all hormonal therapies. We cannot use IUD with hormones. So we are left with tranexamic acid and factor. So if there is a heavy menstrual bleed, I would control this menstrual period with tranexamic acid 25 milligram per kg thrice a day for 5 to 7 days and give on-demand factor. And tell the couple to plan the pregnancy. And as soon as the lady becomes pregnant, at least the menorrhagia issue is taken care of. I would go that way.
So the other issue, sir, we always tell them to continue OC pills is because of the ovarian hemorrhage and they'll end up with hemoperitoneum. So it's not only to prevent the menorrhagia, it's also to prevent the hemoperitoneum. We get patients in shock with hemoperitoneum.
Correct.
So it's always patients need to continue OC pills till they conceive or they plan for pregnancy. So that's an advantage. Otherwise, it causes recurrent ovarian hemorrhage and fibrosis. And the fertility issues also will happen. So that is an added advantage of continuing the OC pills.
In fact, if in the recommendation also you saw, they have said you should use oral contraceptive pills from the angle of menstrual pain and ovarian cysts.
Yeah.
I showed in that recommendations.
Yes,
but
sir.
when the lady wants pregnancy, you'll have to take off OC pills.
Yes, yes.
And then you have to cover this way and plan accordingly.
Another thing which is of management issue, majority of the gynecologists do not know how to manage menorrhagia and bleed in von Willebrand's disease, or for that matter, any of the rarer bleeding disorders. So what I suggest, what I have always suggested to our gynecologists is, if there is normal, to control the normal menorrhagia, start with a progesterone only tablet twice a day or thrice a day, and then manage with maintenance 1 tablet. Then they have a withdrawal bleed. Of course, you have to give, like Shashi said, you have to give a lot of iron, oral iron or IV and whatever it is, to see that their bleeding is. Once they continue that for say 8 to 10 months, you have to change it over to a OCP which contains estrogen and progesterone to prevent breakthrough bleed. Then you allow the endometrium to grow a little bit, and then again you switch back to progesterone. So you have to have a cycle between the pure progesterone alone with a couple of months, 2-3 months with estrogen progesterone combination, again shift back to progesterone. Then only otherwise they'll have a lot of breakthrough bleeding and becomes difficult to control the bleeding in some women.
See, one patient, very affording patient, now progesterone depot preparations are available. You just give a shot of factor, maintain the level at around 20 to 30% and give an intramuscular injection of this progesterone depot. And it roughly works for 6 months. Roughly works for 6 months. Okay. And that has shown to reduce the infertility problems in patients with VWD or any bleeding disorder for that matter. But it is expensive. It is expensive.
You can also intrauterine device, no? I mean,
but then intrauterine device in a nulliparous woman will be dangerous.
Nulliparous,
It becomes dangerous, you know.
Yeah. Nobody.
We had a girl, we waited till age of 18, and at age of 18, with her consent, we did a hysterectomy. There was we had a lawyers from both sides. We had a formal contract done. Because thrice we lost her because of her hemorrhagic shock. And she was requiring very high dosages of hormones to maintain or stop her periods. And she started getting complications of that.
Yes. Madam, anything, madam, any comments, madam?
No, that only. I just wanted to say, what would be your choice of the oral OC pill that you would use?
So progesterone alone will be the first choice. And we also do switch between progesterone alone. After 6-7 months, we'll switch over to estrogen, progesterone, again come back, then withdraw the hormones, support with tranexamic acid and factor concentrates, and try to let the lady plan pregnancy. As soon as she becomes pregnant, in fact, we have a sigh of relief, you know. You actually have a sigh of relief because now...
No, but Shashi, how will they become pregnant if they are on the pill?
No, you stop them. You stop them and support with tranexamic acid, I said.
Yeah,
you stop the OC pills after a cycle. So you have allowed endometrial proliferation to occur. Then you withdraw. There are no OC pills. You just support with tranexamic acid and factor. And hope that rapidly, say in 6 months' time, they conceive.
Yeah.
Yeah. So, yeah. So we have come to the end of our second virtual case conference in hemophilia. So it was wonderful to have you, all of you. And I thank all the speakers for spending their time on Saturday evening with us and giving excellent lectures and discussing the day-to-day problems. And I thank all the delegates. We have at present 450 delegates on portal and 150, more than 150 on YouTube. So totally, we have got more than 600 delegates who are attending this meeting. So we are very grateful to them. And we are very thankful to our sponsors, our platinum sponsor Takeda, and the gold sponsor Novo Nordics, and our bronze sponsor Roche. So, and we are very thankful to our mice ideas. Without them, the logistics would have been very difficult. And Dr. Somnath is always a call away, so he always used to respond to all my calls. And thank all the mice ideas for Kalpesh, Rajesh, and Somnath. So we close this session for today, and hope we'll meet next time with all the basics of hemophilia management. I thank everyone.
Thank you, Chandrakala. Thank you, Farah.
Thank you. Yeah.
Thanks,
Bye-bye.
thanks,
Yeah.
Farah. Yeah, thanks.
Thank you,
Good,
madam.
good, good. Yeah.
Thank you. Thank you.